This is Sarah with registerednursern.com, and in this video I'm going to be covering asthma. And this video is part of an NCLEX review series over the respiratory system. And as always, whenever you're done watching this video, don't forget to access the free quiz to test you over this condition. So let's get started. So what is asthma? It is a chronic lung disease that causes narrowing and inflammation of the airways. And we're specifically talking about the smaller airways, like the bronchi and the bronchioles. And in patients with asthma, these are chronically inflamed. Now remember, with asthma, there's no cure, but it can be managed with medications, which we're going to talk about a little bit later on. And what happens is this patient can become triggered. Say, for instance, that one of the triggers that causes an asthma attack in them is pet dander. So they get around pet dander, it inflames all of these bronchi and bronchioles, and it can send them into an asthma attack. So the patient will start experiencing chest tightness, difficulty breathing, coughing, wheezing, and they will experience air trapping, which eventually can lead to respiratory acidosis. So how does this happen? Well, to understand the pathophysiology of an asthma attack, we need to talk about what we normally do with breathing. So let's think back to anatomy and physiology. So whenever we inhale air and it has oxygen in it. And when we exhale, we're exhaling the buildup of carbon dioxide in our blood to get rid of it, because we don't want to keep carbon dioxide in our blood. If it stays in our blood, carbon dioxide is acidic. It will cause us to enter into an acidotic condition. So remember that. So we breathe in the air, it enters into our upper airway, then it flows down through the lower airway, which is our trachea, into our bronchi, and then that air goes down into even smaller airways called the bronchioles. And then after the bronchioles are these little air sacs, the alveoli sacs. And this is really the functional unit of your lungs. This is where gas exchange happens. And if we took a bronchiole and we had an alveoli sac, you can see that there's a nice little capillary bed around it. And what's happening is that oxygen that you're breathing in is crossing over into that capillary bed, going in your blood and replenishing your organs and doing its job. Now, what's also crossing over in the opposite direction is carbon dioxide, and it's going to flow out, and you're going to breathe that out because you don't want that to build up in the body. Now let's look at what's going on in an asthma attack. So ask yourself, what surrounds these structures, that bronchi and bronchioles? Smooth muscle. These little areas right here in blue represent the smooth muscle. Now, what does this smooth muscle do? It can constrict and dilate. When it constricts, that narrows the lumen of that airway, so not a lot of air is going to flow through, and it can dilate to allow air to flow through. And we give patients drugs that can alter the way that that smooth muscle works, hence bronchodilators, which is one of these big drugs that we give patients who have asthma. Now, say that patient's triggered, like we talked about earlier, they inhaled some pet dander, and it has triggered an asthma attack. So this allergen has came in, and what's going to happen to that smooth muscle? It's going to constrict. It's going to clamp down. And the patient's going to start to feel chest tightness. They're also going to have difficulty breathing because they're not really moving a lot of air when those smooth muscles clamp down like that. Now, let's think about what's inside these structures, the bronchi and the bronchioles. Well, we have a mucosa lining, which has these special cells in it called goblet cells. Now, goblet cells are really helpful on the surface because whenever we breathe in that mucus, because that goblet cells produce mucus, it collects the irritants that we breathe in, the bacteria, things like that, and prevents it from going any further in our airway. But when an allergen like that pet dander that has triggered this patient's asthma comes in, they're overstimulated. So they start producing lots of mucus. And this mucosa lining, which is already inflamed, is going to become even more inflamed. So you got more inflammation and you have this excessive mucus production going on. So what is all this going to lead to? We're going to have further decrease in our airflow because we have mucus in the way and we have severely inflamed mucosa lining. Now this patient's going to start having a cough because of all this mucus and wheezing. And why is that? As air is flowing through this narrowed airway and it's coming into contact with this mucus that's in there, it's going to produce this like musical whistling sound. So you'll be able to hear that, especially on expiratory, whenever you're listening with your stethoscope, expiratory wheezes. But it can become so severe in asthma, if this is a really severe asthma attack, they can have it on both inspiration and expiration. Now, think about what's going to be happening in these sacs. Is air really going to be moving out? No, it's going to be trapped. So you're going to have air trapping in there. And one thing you're going to notice with patients with asthma, if you've ever seen a patient have an asthma attack, they cannot fully exhale. Like, that is one thing that they're really struggling with, which makes sense with all these structures being involved. So if we have air trapping, gas exchange is not going on. So guess what? Carbon dioxide is not going to leave this sac. It's going to stay in the blood. Oxygen's not going to get into the blood, so we're going to have decreased oxygen levels in our blood, but we're going to have increased carbon dioxide levels in our blood. So what did I say that carbon dioxide was? It's like acidic. It will make our blood acidotic. So the patient's going to can experience a condition called respiratory acidosis. Now, asthma attacks vary in severity among patients. So as the nurse, it's really important that you help the patient be able to identify triggers that's leading them into having an asthma attack. Now, the cause of asthma itself is not known. They think it may be a genetic factor or environmental. But they do know that there are certain things that can trigger a person to have an asthma attack, which include environmental factors like smoke. This can be first-hand, second-hand smoke, pollen, pollution, perfumes, pet dander, dust mites, pests like cockroach droppings. Cold and dry air can make those smooth muscles on the airways constrict down, and mold. Another thing would be like body issues, like the patient has a respiratory infection. This can trigger an asthma attack. GERD, hormonal shifts, especially in women, and it can be caused by exercise, so exercise-induced asthma. Another thing is the intake of certain substances like drugs. For instance, beta-adrenergic blockers that are the non-selective, and we've talked a lot about this in our cardiac videos. NSAIDs, aspirin, and preservatives like those sulfites. So all these things, depending on the patient, can trigger an asthma attack, and they need to be educated to avoid these things. Now, another thing that the patient needs to be educated on are those early warning signs and symptoms that an asthma attack may be pending. And these signs and symptoms can present about 1 to 2 days before a full-blown active asthma attack is happening. And here we're going to compare the early versus the active signs and symptoms. So whenever you're talking to your patient about these early warning signs and symptoms, they're also going to hopefully have an action plan, which is developed by the physician. And here's what a basic action plan looks like, and they're based on zones. And you have green zone, a yellow zone, and a red zone. And based on the patient's signs and symptoms, and if you notice in the yellow, we're starting to get in that early signs and symptom category, the patient's asthma is getting worse because they have coughing, a wheeze, maybe have chest tightness, they're waking at night, and they can't do their activities as normal. And based on that, they will take whatever they need to help control that asthma, keep a full-blown asthma attack actually coming on. Now, another thing they can do is use a peak flow meter device. And these devices are just really awesome in helping a patient learn if their asthma is getting worse and helping them prevent them from actually having exacerbations of an asthma attack. And here's what one of those devices look like. And what the patient does is the patient will fully exhale as hard as they can on this device, and we'll tell them how much airflow is actually coming out. Because remember, with asthma, we're having airflow issues. And in the nursing intervention part, we will talk about how to use this and how to provide education on this, but I just wanted you to get familiar with that because the action plan that you just seen goes along hand in hand with those patient signs and symptoms and using that peak flow meter. Okay, so early signs and symptoms. All of a sudden, the patient is getting easily short of breath where they normally weren't. Or they're easily fatigued with physical activity. So if these are happening, the patient needs to know, hey, something's going on in my airway. Another thing is that they're getting that frequent cough, and it mainly starts to present at night, and that's that excessive mucus production by those goblet cells, and this will lead to them having issues sleeping. So they're not going to sleep good at night. They're going to look extremely tired, which is going to lead to irritability. Also, they may have signs and symptoms that's similar to developing a cold, like they're sneezing a lot, having a scratchy throat, and tired, and they may start to notice that they wheeze a little bit with activity. And if they're using a peak flow meter device, that they have noticed that based on their personal best reading, that their reading is dramatically reduced. So there's less airflow coming out. Now, what are those signs and symptoms of an active asthma attack that is literally going on and this patient is experiencing it? They will have the chest tightness, and remember we went over why they're having the chest tightness, that smooth muscles clamping down. They have wheezing, and as a nurse, if you listen with your stethoscope, you can hear expiratory wheezes. If it's really severe, you could hear it on both inspiratory and expiratory. They will just have this coughing that won't stop, and it's just cough, cough. And dyspnea, difficulty breathing, and especially exhaling, increased respiratory rate, of course. And all of this can, if this is not treated and taken care of, like with bronchodilators and getting some corticosteroids in after the bronchodilator, giving them oxygen, things like that, this can progress to where those bronchodilators, those short-acting bronchodilators, the rescue inhalers, won't even work. Like they're beyond the point of that even working. They're not going to be able to speak to you. Talking just isn't happening. They're trying to breathe. Also, they can have chest retractions, and what this is the stomach will be sucked in, the ribs will be pulled out. It'll literally look like the skin is stretched over the rib cage. The clavicle, the collarbone will be protruding out, and this is where they're like just not getting any air in. And if you see that, that is an emergency. Also, cyanosis is going to appear. You're really early, you'll start seeing it in the signs in the lips, and it will be like this dusky blue color. I know a lot of patients I've seen, it's just like this little ring of blue forms around their lips. Sometimes it can be like this dark purple burgundy color, and then it can progress to the skin. This is where they are not getting oxygen to the tissues, because remember that oxygen exchange is not happening in that capillary bed. We're not having the airflow because of the air trapping. Also, they'll become sweaty. And when these are happening, the patient needs medical treatment really fast. They may need to be intubated, get mechanical ventilation, IV corticosteroids, and things like that. Now let's look at some more nursing interventions. Okay, let's talk about if your patient is presenting with an asthma attack. What are you going to do? And of course, depending on how actually severe this attack is, because every patient can vary, you'll have to tweak some of these. But of course, first you'll want to do is get vital signs, because you want a baseline of where your patient currently is at, because you're going to be giving them treatments and you want to see if they're responding to these treatments. Is their oxygen saturation increasing? Is their respiratory rate going down into the normal range? Is their heart rate slowing down? Are they doing better? So you want to do that. Also, you want to keep calm, and you want to help keep the patient calm. You don't want to communicate to the patient in your nonverbal language that you're anxious, you're scared, because that's going to make the patient even more scared, because they're already anxious because they can't breathe. With positioning, you want to keep them in high Fowlers to assist them with breathing to make it easier. Per the MD order, you'll want to give them bronchodilators. And what type are we going to give? Are we going to give short-acting, long-acting? We want to do short-acting, and we're going to go over those here in a second in depth, because we want something that's going to act fast and dilate those airways so this patient can breathe. Want to give them oxygen, keep the oxygen saturation between 95 and 99%. We want to assess those lungs before we're going to give them medications, because we're listening for that wheezing. While there may be respiratories there, giving them a nebulizer treatment. And after, we want to see how has that wheezing decrease? Are they breathing better? So listening with our stethoscope to that. Also assessing for cyanosis in the lips and the skin. Are they getting good oxygenation? And those chest retractions that I was talking about, if you see that, that is not a good sign. And their ease of speaking. Can they speak to you now? Or are they can't speak because they're so short of breath? Then assessing their peak flow meter reading. And we're going to talk about that here in a second more in detail. But while all this is happening, if your patient can communicate to you, you want to get a baseline of what their peak flow numbers are, because a lot of patients with asthma use these devices and they know what their personal best number is. And based on what their personal best number is, on a percentage, you can see if they've decreased, and if they've been using their peak flow meter before they came to you, what was the reading? And whenever you're collecting theirs, you can compare the two. Also, medications. Have they already taken a bronchodilator? Has it not worked? Which is a big warning sign. So you want to see what all they've tried before they've actually came in. Now let's talk about that peak flow meter. Okay, what does it do? Again, it shows how controlled their asthma is and if it's getting worse. And I want to cover this because when you're taking care of patients with asthma, you're going to come into contact with these devices, and I want you to be familiar with them and how you would educate a patient on how to use them. Okay, so this peak flow meter, it looks like this. And again, remember, you exhale fully on it, the patient will, and they will do that several times, and they will measure their readings, and it's used along with that action plan that we went over earlier, and it lets the patient know when they should use their short-acting bronchodilator because they have some issues going on in there, because we want to prevent a full-blown asthma attack, and when it's actually time for them to get medical help. Now, how does this flow meter do this? Well, whenever a patient's starting out using a flow meter in the beginning, they need to figure out their personal best flow meter reading number. And this will be the highest number that they reach over a period of time. And this number will be used to compare against other reading numbers to make sure the patient's asthma is under good control. So whenever you have a patient with asthma, you want to ask them, well, what was your personal best peak flow meter reading? Because that's going to help give you a baseline of where they should be while you're providing care. So to figure this out, the patient will do this when their asthma is under good control, not when they're having asthma attacks and issues with that. So they want to do this to figure out the personal best meter flow reading is whenever their asthma is under control and doing good. So they will measure it once in the morning and once at night for 3 weeks usually, and record the number before taking the medicine. So they'll keep this little log of this, and then whatever the highest number that they got during that period is their best peak flow meter reading. Then, just to keep their asthma in check, to keep monitoring it, they will need to check it at the same time, either in the morning or at night, before taking their medication, and compare it with their best reading. And generally, if it's less than 80% of their personal best, they'll want to follow the action plan that they developed with their doctor. So you're going to educate your patient how to follow the asthma action plan, and you're going to go over each zone with them, the green, the yellow, and the red, and explain to them those signs and symptoms, what their peak flow meter reading is, and what they need to do, what medications they need to take, and how often according to whatever the physician wrote. And you need to quiz the patient and make sure that they understand how to do that, because following these action plans and using the peak flow meter really helps decrease the patient being admitted with this asthma exacerbation. So really help preventing them having to even come to the hospital is great, along with teaching them those triggers that we just went over earlier and those warning signs. However, you may be thinking, well, how about they can avoid pet dander, they can avoid pollen and all that stuff, but are they supposed to really avoid exercise because they have exercise-induced asthma? And the answer is no. They need to exercise. They don't need to quit, because exercising is good for overall health. So they can do some things that can help prevent making an asthma attack happen, like warming up 10 to 15 minutes before exercising. Also taking a short-acting beta agonist before exercising, so getting that bronchodilator in there. Also, if they choose to exercise outside on a cold, windy day, because cold air can cause that smooth muscle to constrict, which can trigger an asthma attack. So they need to breathe through their nose, which will help warm the air before it actually comes down into the lungs instead of mouth breathing, and use like a scarf or something over the mouth to prevent that cold air from getting in there. Also, if they have a respiratory illness, a cold, something like that, they want to push off exercising until they recover, because remember, respiratory illnesses can aggravate asthma. Now let's look at our medications used to treat asthma, and we're going to put these in two categories. We're going to go over bronchodilators and anti-inflammatories. So first, let's cover bronchodilators. What do bronchodilators do? Just like the name says, they are going to dilate our bronchioles, our bronchi, the airway, so that patient can get better airflow and oxygenation. Now we have several types of bronchodilators. We're going to be talking about beta agonists, anticholinergics, and a drug called theophylline. All can perform bronchodilation. So first let's talk about beta agonists. These are generally given the inhaled route whenever you're having asthma issues. And the first type of beta agonist is called the short-acting beta agonist. Hence, they work fast. They give us fast relief. And a common type of drug used is called albuterol. So if you ever see albuterol, think short-acting bronchodilator. And this provides fast relief during an attack. Now, it's not used for daily treatment. So this patient isn't going to take this every day. And as a nurse, one thing you want to ask this patient who has asthma, ask them, how often are you using your albuterol inhaler? And they shouldn't be using it any more than 2 times a week. And if they tell you they're using it more than 2 times per week, you need to report that to the physician, because there needs to be an adjustment in that patient's asthma plan because their asthma is poorly controlled. Okay, another type of beta agonist is a long-acting, so it takes it a little bit longer to act, and some drugs are salmeterol or Symbicort, and Symbicort, you will see this a lot, is actually a combination. It's a long-acting bronchodilator and a corticosteroid in one inhaler. And these long-acting beta agonists are never used alone. They are used with corticosteroids, and they are not for an acute attack. So this is not what you're going to be giving a patient during an acute attack. They need something that's going to work fast, like albuterol. Now, there are some side effects with these beta agonists. They can increase the heart rate, cause tachycardia. So if your patient already has tachycardic, if they're already tachycardic and they're running like 120s already, and they need a treatment of something like this, may want to pick something else, like an anticholinergic bronchodilator, which will really not affect the heart rate as much. It can also cause the patient to feel jittery or nervous. Now, a lot of times patients tell me, I just had my nebulizer treatment, I feel nervous and jittery. And these can cause that. And again, the heart rate, if they're on you want to monitor their heart rate to make sure they don't have any dysrhythmia. Next, we have the anticholinergic bronchodilators, and these are inhaled as well. And you have 2 categories of them, just like how you had with the beta agonist. You have short-acting and long-acting. So with the short-acting, a common drug is ipratropium, and this is used a lot of times when the patient can't tolerate those effects with the beta agonist, that increased heart rate, things like that. So the long-acting popular kind is tiotropium, and so it's a little bit longer acting compared to your short-acting, and because these are the anticholinergics, they can cause dry mouth, so let your patient know that. And to help with that, they can take sugarless candy, which will help increase the production of saliva so their mouth isn't as dry. Then we have a drug called theophylline, and this is a pill. It's oral, and this drug is not used as much as those other ones. It's not one of the first-line treatments, but I want to go over it because in the hospital you will encounter some patients who take this medication. You want to be familiar with it. It's not prescribed as much because there's issues with toxicity, and you have to maintain these constant blood levels. And the blood level you want for theophylline, now remember that, 10 to 20 micrograms per milliliter. And some education pieces with this is that they need to avoid consuming products that have caffeine, because caffeine has the same properties as theophylline, and when you're throwing caffeine in the system along with theophylline, you're just increasing the risk for toxicity. So avoid caffeine with that. Now let's look at our anti-inflammatories. Okay, we're going to go over corticosteroids, we're going to go over the leukotriene modifiers, and the immunomodulator drugs. Okay, so first, corticosteroids. What are they going to do? They're going to help decrease that inflammation. In a sense, they're going to suppress our immune system. And there's various routes patients can take these. Most common is the inhaled route. So let's throw a question out there. You have a patient who's on a long-acting bronchodilator. They need that, and they also need their corticosteroid inhaler. So you have two inhalers you're going to give. Which one are you going to give first? First, you're going to give the long-acting bronchodilator, because that's going to dilate the airways, and then you're going to wait 5 minutes and then give the corticosteroid, because that corticosteroid can then get in the airway and do its job. Now in severe cases of asthma, they may need an IV and PO route for a while, and corticosteroids are long-term treatment. They are not used in an acute attack, and it helps prevent those signs and symptoms of an asthma attack. And some common drugs include fluticasone, budesonide, or beclomethasone. And one thing you need to watch out with these inhaled corticosteroids is that they can cause thrush. And to help decrease the patient from developing this, whenever they're using their inhaler, they need to use a spacer with that. That dramatically decreases the chances of them getting thrush in the mouth. And another thing is, after they get done using their corticosteroid inhaler, they need to gargle and rinse the mouth with water and spit that water out. Again, these are used, like I said, 5 minutes after a bronchodilator, if a bronchodilator was ordered with that. And these medications can cause osteoporosis over time, especially in women. So if you have a woman who's postmenopausal, she's at risk for this because she has low estrogen levels, which lead to bone thinning anyway, so they need to make sure they're getting calcium and vitamin D, and can also cause cataracts as well. Okay, another type of anti-inflammatory is leukotriene modifiers, and these are given orally in a pill, and a common one is Montelukast. And how these work is that they block the function of leukotriene. And what does leukotriene do? Leukotriene causes our smooth muscle to constrict, and it increases mucus production. So what this drug does is it blocks that from happening. So what's going to happen? We're going to have relaxed, smooth muscles, so we're going to breathe better, and we're going to get decreased production of mucus. So you're not going to get that mucus in there blocking that lumen even more. Now this medication is not for an acute attack. It's for long-term treatment. Another type of anti-inflammatory is omalizumab, and this is given sub-Q, and it blocks the role of the immunoglobulin IgE. So whenever that's blocked, because it plays a role in our immune response, we have a decreased allergic reaction, hence decreased asthma attacks. Now, this drug is used in patients whose asthma is poorly controlled and not being affected by these other treatments we have went over. So in a sense, it's like one of those last resorts. Now, it's not for quick relief, and if your patient is taking this, they need to receive no live vaccines. Another type of anti-inflammatory is cromolyn, and this is given inhaled like a nebulizer. And it's a non-steroidal anti-allergy type medication. And what it does is it stops mast cells from secreting histamine. And we know that histamine plays a huge role in an allergic response. So whenever you have decreased histamine, you can calm everything down, patient can breathe better, you have decreased mucus production, decreased swelling and inflammation. It's not for long, it's for long term, it's not for quick relief. So patients having an asthma attack, you don't want to just give them this. Instead, this is like part of the long-term treatment. Now, if a patient is receiving this, sometimes they can complain of a burning sensation of in their nose, or a bad taste in their mouth, along with starting to sneeze. They can get itchy, watery eyes and things like that. So if that happens, just reassure the patient it's a temporary side effect of this medication. Okay, so that wraps up this NCLEX review over asthma. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.